ma'am is of course heading and has been a mentor, a teacher for teachers who are currently teaching strabismus. She has been leading with examples, with some outstanding work for over, I would say 30 to 40 years since I've been seeing her. Like I said, almost everybody here has sometime or the other, directly or indirectly, been her student. It's always a pleasure meeting and listening to ma'am. She'll be giving her keynote address on prescribing spectacles to children.
It's going to be good afternoon. When Namrata asked me, select a common topic, madam, for AIOS. So I thought maybe this may be appropriate as an experienced one, what exactly that I can convey to the junior persons, or I was expecting more junior fellows here to know about the facts. So what is it? We all know spectacles, children, is a very good method for correcting refractive errors. But it's not only for improving the visual acuity, but it also helps in developing the visual system on the whole. And giving prescription is not only the numbers, as what we all think. Decision on the numbers is very easy, but how it can go to a child in all respects as a holistic approach with the tips on lenses and how to make this child to select a frame, that is more important. More than that, all of you would have been seen these children would have been less compliant to our the prescribed spectacles. So how to make them compliant to it? That is, the motive should be there behind us, rather than just giving the numbers and then asking them to go. So what is the goal? All of us have a goal. See, most of us think that by improving the lines of visual acuity, that is the end of the prescribing spectacles. But that is not the end. Just by giving numbers alone is not enough. We should not ignore the following facts when they have symptoms due to asthenopia, or any symptom of strabismus could be intermittent, or any site of a glare photophobia when a child comes with albinism or rod cone dystrophies or cone rod dystrophies. So we should be aware what is the associated symptoms and how do we address the same along with the numbers what we are prescribing. So first, coming to the number, even before deciding the number, the basic requirement is, all of us know that cycloplegic refraction is a must. At least for the first visit, a child when he is coming before the age of 12-15 years, we prefer to do at least one time a cycloplegic refraction. And the revisits decision is on the individual basis. And the refraction, and now all of you are prefer autorefractometry, well and good. But even then, the streak is good in verifying both comparison, because some children are non-verbal. So comparing these two will give a better idea for you to get a value what exactly you need to prescribe. And this is what the drugs what we practice in our system in Aravind Eye Care. So how does it? Refraction most of the time must have been done by somebody else, or optometrist or refractionist, whoever is helping you. But when you check, what are things that you should be checking it? There should be a good correlation between the retinoscopy values and the subjective values what you have got. And there should be a good correlation between uncorrected visual acuity and the amount of error you are giving. There is 636 person accepting minus 1.5 is perfectly all right. But a 636 uncorrected accepting 3 is something unusual. So that just give a red bulb in our mind that to think about redoing the refraction. And if there is any symptoms of asthenopia, whether the fogging method has been done during retinoscopy. And cylinder axis, whether it has been correlating well with the K reading through whatever means that you want it. In anisometropia, what is our goal? Are we giving a good binocularity, or are we giving good individual good visual acuity? That should be done by binocular assessment. And in general, a higher ametropic or astigmatic or eye with an astigmatism at off axis should be the eye with reduced vision. Sometimes you do see opposite. That depends upon how the subjective has been done, how the refraction has been done. If that is the deviation that what you see, it is better to ask for a re-refraction. And then what should be on the follow-up visits? Follow-up visit complaints could be totally different from a first visit. So elicit the present problem. If there is any thing on the structure of the frame and the lens, you just clarify it. And then when you, after doing your refraction, if there is a jump in power, and then assess like what we did in the first time, the uncorrected vision or corrected vision with the spectacles, all the things. And if needed, if there is a more jump in the power, especially in myopia, accommodation and axial length measurement should be done, because there is lot of things going on for myopia management. And the change in the axis, usually you refrain from giving a different axis power until you confirm with your K reading. And anisometropy, again repeat your binocular visual functioning, and if it is necessary, a binocular balancing. And now exactly how it is the decision of the numbers. This should be based on the age and the point that myopic shift is going on. For 3 diopter shift is going on per millimeter of axial length, especially in the first 3 years of life. And that goes on till 6 years of life for a little bit moderate phase. But after that, even it occurs up to teens in a slow pace. But depending upon that, you give the correction to enhance the process of emmetropization. So basically, a partial correction when there is a long, below the age of 6 years, especially below the age of 3 years, and then full correction depending upon the subjective and complaints, complaints from the patient, you give a full correction. That is the practical point that we follow it. Not moving? Yes. So this is the guidelines given by AIO. Any books you can find it, but these are only, you can take it as only guidelines. You have to individualize the patient, and if there are any risk factors you think there are present for amblyopia, even a small refractive error should be corrected. And a moderate hypermetropia, usually we wait at least for one more visit to see before correcting, because if you give correction in the early age, no other symptoms, a moderate hypermetropia, it's possible that child will retain the power and early presbyopia will get settled in. So a right prescription, what should be there? Along with your numbers, there should be the line, what exactly the lens or the frame you suggest for that particular person. That means what I feel is a holistic approach in prescribing spectacles. So what are the right lens that you will suggest for these children? As their anatomy is different, they are going to fall, get it injured. So now the lenses you have to select depending upon that. Many things are available, but recently the polycarbonate lenses have been in the market, and it's not very expensive, you can give it. And this should be light and thin. If it is heavy, no child will like it. And naturally, it has to be break-free and impact resistant, and almost UV protection. So what is that in myopia lenses? In practice, standard lenses, this basic aspect of lenses, I think we all ophthalmologists should know. That CR39 is the basic lens which is available in the market. So this lens is quite cheaper, but the lens is thicker. So when you are dealing with the low economic group children, or when most of seniors are there, engaged in screening for school children and giving free spectacles, this is the best lens that you can give for free. But when there is a weight and thickness is the question, then you go for other lenses. There are available lenses, PMMA lenses, polycarbonate, MR8 and Trivex. All these lenses are available, but little bit costlier than the standard lenses. And what about these high index lenses? Do we suggest them at least this is available? So once they go to the optical shop, if they explain people have a scientifically, they will have a negative aspect. Maybe these people are pushing it for a business. So scientifically, if you feel this child will act good with this, then you just recommend them. You just have this high index lenses, especially when the myopia power is more than 4, and especially more than -6. This definitely helps by reducing the thickness by 50%. And what are the frames? Small errors up to 4-5 errors is okay. They can have, the children are very well oriented to the fashion now, so there are many frames available. They can go for it. But for higher powers, you have to recommend saying that the frame should be thick and full frame, because the edges are quite thick. Otherwise, it will cosmetically look very bad for the child. So what is it follow-up? We all know, I think there is going to be a session, next session, what exactly that you have to follow up myopia. But in general, if there is increase of more than 0.5 diopters increase in a year, then you have to think twice and then do the investigations and then think about what to prescribe. And in general, we believe in doing a cover test and binocular functions, including accommodation amplitude measurements. And then if there is accommodation lag is there, we consider Paul lenses. If the patients are orthophoric with normal or very low accommodation lag, and then we suggest them defocus lenses. I think the details you will have it in the next session. Coming to hyperopias, again, hyperopias we have seen, it's very common. And when asymptomatic, you don't have to train a moderate degree of hypermetropia. It's only the amount what is really needed to achieve that you have to give. That is why we talk about a partial correction in these conditions. And also in terms of exo deviations, you think twice before giving full correction. But when you have an esotropia due to accommodation problem, there is no compromise. Because you are going to have advantage of developing binocularity and then good alignment, so you prescribe a full correction. This is the basic indication what you have. And when you give a bifocal, when to give it bifocal in general for any practicing person is whenever there is a difference of deviation from distance and near in accommodative esotropias. When more than near deviation is more than the distance and need extra power, then you give the spectacles for near correction, but make sure what exactly the lens you want and what exactly the segment between upper and lower segment you want. This is what the requirement that you have to give. So this shows this child has got esotropia. With the glasses, yes, some amount is corrected, but still it's not fully corrected. Its near segment is there, but it is not a proper way of wearing the spectacles. Supposing, see, child looks through the lower part is good. So the frame should be, it's not snugly fit on the nose. So it should be straight like this and then fitting snugly on the nose pad. And then if possible, if it is not happening, you have to ask them to have a nose pads to support it. And these are all the small tips. If you give them, their compliance will automatically increase and they will come to you. They will be there throughout their growing age group. So what is the follow-up? Depending upon, usually, as we said, myopic shift is going to be there. These children also will go for myopic shift. So check them every 6 months, reduce the power by -0.5 steps or 0.75, whatever you feel like. First do it for, if there is bifocal, do it for near and then go for a distance. If it is a distance alone, go in steps. Usually if the accommodative esotropias, they retain the power for distance. And near sometimes they get rid of it. In that case, if they really want it for continuation, you can suggest even contact lenses. Coming to the astigmatism, most babies and infants will exhibit astigmatism. Some amount of astigmatism, at least a little bit more than -1 diopters, and it usually gets resolved like our epicanthal folds. Usually it gets resolved by the age of 3 years. But if that is going to be in oblique axis as you do your auto-K or K reading, then you should think about giving prescription even that age group. And after 3 years, I think to certain amount of subjective should be possible, then try to give a full correction. And follow up also here, one important thing here is now more and more children, as they are growing, they are also having allergic conjunctivitis, and keratoconus is being on increase, increasing occurrence. So you have to be very careful. You check the axis. If you feel there is a change in the axis, that should give a cautious in your mind and try to do op scan and then see the irregularities on the cornea before you prescribing changing the glasses. And coming to anisometropias, we all know anisoconia is a problem which causes this thing, 2% for increase in the size of the images for 1 diopters. So that is what we say, up to 5% a child can tolerate. But children, when infants, I have seen even -10 or +10 even affects. If the eye is not microphthalmic, normally developed eye, they accept very well if you give them at the age of 3 or 4 months. But later on they may not be. But very young children, they accept even anisometropias of large thing. So that should be, if there is more than 4 diopters, you think about checking for the fusion. If there is a fusion, it's a small exophoria and eccentric fixation, you just give only a single vision glasses, perfectly all right. You don't have to think about anisoconia there. If that is more than that, then you have to do a binocular balancing. What we mean is, you just reduce the power in the hypermetropic eye and then check for the vision, the maximum vision with no double vision, that is the binocular balancing, you give it. But if the child or the parent wants, no, we want a full correction vision for that, then alternative is only a contact lenses. So aphakia, this again one more, Anil Kumar, I think you will remember this. We have been talking about this even quite earlier, about this aspheric lenses. Because the children, when we give aphakias, the thick lenses are so thick, they have very heavy and then it falls down because it shows +20. And then we found that this aspheric lenticles are found to be very useful because this is going to be only transient now. After some time, we are going to have anyhow secondary implants. So only for age of 1 year or 1.5 years. So this is what they will wear very comfortably. And then give only distant correction like this for the actual refractive error. And then near vision add as 18 months because it is the time they use their eyes for an year. And what about the frames now? Again, the frame should fit like this. What exactly it put on the nose also fit on the earlobe. And that should be the frame that you should select. Sometimes the patients will come to you, Madam, can my child wear this frame? So you should be able to give some idea to the parent about whether that can be worn or not. In pseudophakias, I think I don't have to say anything about it. So clear pseudophakia, initially what we practice is at least 3 to 6 months time till some amount of astigmatism you do see in children rather than in adults. So you just wait for that resolving completely because lenses are going to be expensive before prescribing, suggesting a progressive lenses. And glaucoma, what do we do on the children? Invariably, I think you should have some educate the glaucoma surgeons, whoever is treating, that look for, whenever there is an enlarged eyeball, enlarged cornea, look for the presence of myopia. So they will treat the eye completely and then they would have ignored the myopia occurrence and then child will have low vision. So when we give glasses, they will perform well. So make sure that is being done routinely as they come for a glaucoma follow-up. Then the refraction should have been, or axial length measurement should be done clearly, and avoid giving prescriptions when there is very active corneal edema or corneal scar, unhealed corneal scar. Just wait for some time to get better and then give the prescriptions. So when children comes with albinism or aniridias and those who want tints, what exactly to be done? See, tints prescribing should not be universal. So earlier when we say, just go for gray tint, this is a common way of prescribing tints. But this gray, the tints, different tints sometimes will alter the color perception of these children. So we have to be careful when you prescribe it, unless you should give a trial to check. See, albino, what we expect, either she will accept either blue or black gray screen. So, but this child is feeling better with the
Of the three, which one we
yellow
will
lenses.
find
So
more,
that is the difference. All
second
prints
one,
are available in the
green one.
market
Let's try it
with
again.
complete UV protection, but that should be given a trial
This you
before
are
you
comfortable?
prescribe these lenses. This is all of us know polycarbonate. Even now, regular lenses are being made in polycarbonate, so that is not a big problem. So you know whom all suggest then. Coming to important section, let's conclude with this compliance to spectacles. How do we increase the compliance in these children? We have done a large study about 4 lakhs children, and we have found the compliance is 40-45%. It is not the patients to come to us, it is a patient in the community. But even for them, how do we increase their compliance? So few hints on that. So myopia, you just give adequate power with the maximum clarity. Don't give more power as you see in your retinoscopy value. Do not overcorrect hyperopes. And do not prescribe a large cylinder for any patient who has not won cylindrical correction earlier. Maybe go with the little bit half amount and then check the next time and then give full correction. If you give full correction first time, definitely they are not going to listen to you. And astenopic symptoms, you have to address it. Don't ignore addressing the astenopic symptoms. And then with the adequate counseling about the safety, about other things. And in the follow-up steps, again, if what is the problem, they are not compliant or whether they are compliant. Get it and then try to solve those problems. And if there is a minor change in the power, unless there are scratches or any other indication to change, don't change it, because they are not going to be satisfied by giving a 0.25 increase in the power. And then cyclorefraction, whenever is needed, it's a big change or anything, you should not hesitate to do a cyclorefraction. If there is a change in the power, just don't give a prescription. Discuss with the parents this about the problem and about the other factors which is causing it before giving the prescriptions. And so my astigmatism, pseudo-fakes accept the astigmatism tolerate it very well. But these children, when you change the axis, you have to be very careful in changing the axis when they come to you. So ideally, the spectacle should be like this. So well-centered frame and centering frame should be wide enough so that there is just a slight clearance between the frame temples. Usually we say, no, you should be able to pass your finger like this. Then that is perfect. If this should be here exactly like this, and this should be on the ear. So these 3 points, what we say, these 3 points, if you know, and then to know how do we check the frame correct, that 4 touch points. If there is a frame, whether all the 4 things are touching on the thing, I don't have the slide there, then it is perfectly all right. So it's a combined science with art. I think we have to, if you develop this, you will enjoy. You don't feel like that I am seeing almost only the refractive error patients, but each child is going to be different. You will definitely enjoy these children giving prescriptions if you really combine your science with your art. Thank you very much.
Thank you, ma'am. Thank you very much for a very comprehensive view about how we can prescribe spectacles to children and the need of our understanding the very basics that are there. It's essential. Just doing surgery or just doing a refraction is not adequate in them. It's very important to see them and, as you mentioned, follow them up for compliance.